Uh, Hi, class. This is Dr. Weaver again, and we will be having a discussion, or I will be talking about end of life care. As I'm sure you all are aware by now, as a healthcare clinicians, this will be a major part of your job. Um, and in the beginning, of course, if you're not used to taking care of someone who's dying and someone who actually dies under your care, it can be a pretty uncomfortable situation. It kind of reminds us of our own frailties and that we too can experience the same. So that's a little difficult to deal with at times. But we do aim to provide you with some tools to hopefully help you to work through each process. I will tell you, I mean, I don't want to say that you can become jaded, but you do get to the point where it doesn't affect you as much. Hopefully, you'll get to that point. And that's not to say that you're not human. Um, but we all just learn how to deal with a variety of situations, especially uncomfortable ones. So anyway, without further ado, um, so we're dealing with end of life care. Again, a very uncomfortable phenomenon, but yet it requires us to assist these patients in dying with dignity. Right, so death and dying, certainly a part of the life cycle. Nurses can affect the dying process. Depending on what we do, it might be a good death for that patient, meaning peaceful and meaningful, or it can be a bad death, death without dignity. The most common cause of death, as you will read in your textbook, is heart disease, followed by cancer, chronic lower respiratory disease, etc. And of course, the presentation on cultural awareness is something that you need to bring back and incorporate in this death and dying discussion, because as you know, people of various diverse backgrounds, they deal with death in different ways. So always good to keep that in mind. Again, death is a part of the normal life process. It is often feared as a time of pain and suffering. This is the reason why a lot of people, they don't like that discussion or the realities that death or dying can certainly overtake any of us. We think about that suffering process, if you will. Again, the nurse can ensure that the patient dies with dignity, which is a good death, or it can also be without dignity, which would be referred to as a bad death. Now, a peaceful death is one that is free from avoidable stress or distress and suffering for patients and families, in agreement with the patients and families' wishes. We have to honor their wishes, and also consistent with clinical practice standards, which is what we're teaching you now. Most people die after a long period of illness, be that cardiac, respiratory, renal type of diseases. They also, most people also die when they're 65 and older. In some countries, the caregivers are actually compensated for providing care for their loved ones, which I wish the U.S. would do the same. Many healthcare providers view death as a failure, and you shouldn't. I mean, as long as you do everything that you're supposed to do, hey, then you must be satisfied with your efforts. They have done a certain certain studies that had shown that in the U.S., hospitalized patients have a poor quality, as far as poor quality of dying experience. And essentially, because of this study, some progress has been made in order to improve this death and dying process for our or for those who receive our care. Now, death is defined as the cessation of integrated tissue and organ function. It is manifested by lack of a heartbeat, spontaneous respirations, and also irreversible brain dysfunction. Now, death is usually a result of illness or trauma that overwhelms our compensatory mechanisms of the body. Our bodies would try to compensate in order to try to get us back into that homeostasis state. And of course, these mechanisms become overwhelmed until a patient eventually succumbs to cardiopulmonary failure or arrest. Now, direct causes of death include heart failure secondary to cardiac dysrhythmias, myocardial infarctions, in other words, a heart attack, or also cardiogenic shock. Respiratory failure secondary to pulmonary embolism, a heart failure, pneumonia, and lung disease also are implicated here. Now, inadequate perfusion to body tissues deprives, when you do have altered perfusion or inadequate perfusion to our body organs and tissues, it deprives the cells of their source of oxygen. Whenever your cells of your body is lacking in oxygen, it leads to anaerobic metabolism, which causes acidosis, which we will learn about acidosis in the next couple of weeks or so. And then, of course, it leads to hyperkalemia or increased potassium and tissue ischemia, meaning the tissue is not getting any oxygen. And so you'll learn that body cells, our body organs and systems cannot thrive in an acidotic environment, in an environment with increased electrolytes such as potassium. The body just can't withstand that. Now, when someone is hypoxic and they're in an acidotic state, in other words, they have that acid-base imbalance where you're more acidotic, or a pH of less than 7.35, especially around 7.25, major problems. This results in lethal dysrhythmias such as ventricular fibrillation, which basically the ventricles are just fibrillating. They're not squeezing, getting a good cardiac output to our tissues. So these patients can develop, as a result of this acidotic state, ventricular fibrillation, asystole, meaning a flat line. And this ultimately leads to decreased cardiac output and perfusion. And of course, our tissues and organs begin to starve because it does not get, they don't get adequate nutrients, oxygen, minerals, and so forth. Again, many of those things we'll learn about during our discussion about various diseases and disorders. Now, as far as planning for end of life, there are things that patients can do to ensure that their wishes are carried out, because let me tell you, when you start getting family members involved in that, in that process, you got one family member, a group over here who opposes certain things, and the other one opposes those other things, and of course it becomes very uncomfortable for everyone. So, which is why we all, as uncomfortable as it might be for us to discuss and to plan for, it is better to put a plan in place. So you have the Patient Self-Determination Act, or PSDA. Most people prefer to die at home, by the way. Now, there are documentations or documents that are associated with patient self-determination. It is the Advance Directive. There's a durable power of attorney. There's also the durable power of attorney for healthcare. There's the living will, and also do not resuscitate, or what we also call DNR, an order that you'll see on some patients, um, who desire to not be resuscitated in the event that their heart stops beating and they lose spontaneous respiratory efforts. Now, the DNR orders, and you have to have an order. The doctor must write the order for DNR after they have this discussion with the patient, and the patient or the caregiver decides that they want the patient to be a DNR. Then this is the order that must be placed into the patient's chart. By law, healthcare providers must initiate CPR for a person who is not breathing, or if they don't have a pulse, unless they have a DNR order. It can be written in advance, which is a portable DNR. Major problems with the DNR is that there are unclear variations. There's so many different types of DNRs. There could be, all right, so you can do resuscitation and medications, but you can't do intubation and chest compressions. Or you can do intubation and chest compressions, but no medications. I mean, it's so variable. And of course, heroic measures together in combination is what increases a patient's survival. So if you tell me to do everything except shocking the patient, they're likely going to die anyway. So don't know if we really take the time to explain these things to patients. It might be pretty difficult to explain. I don't know. It can be perceived by family members to mean that they have been given permission to end the patient's life, which can make it really, really difficult for them. Now, Congress in 1991 passed the Patient Self-Determination Act, which did grant Americans the right to determine the medical care they wanted if they became incapacitated. Documentation of self-determination is accomplished by completing an advance directive, or AD. The what do you call it? The Patient Self-Determination Act requires that a representative in every healthcare agency ask patients when admitted if they have written advance directives. You want to ask your patients about this, especially if you think about their diagnosis. Someone comes in with a diagnosis, you know that they could be checking out at any given time. You want to ask them about that. And to be honest with you, you may want to even ask some of the younger ones about it, because you just never know. Some people may be mature enough and may know what they want, where they want an advance directive. They don't want all these crazy things. You never know what patients' experiences might be like. Now, an advance directive should be done or completed long before a medical crisis occurs. So you don't want to do it like almost on the spot or near the crisis. Advance directives, they do vary from state to state, but are readily available through Caring Connections. This is an online program of the National Hospice and Palliative Care Organization. And I did provide you with a link to that if you would like to peruse that website later. Generally speaking, most have a section in which one names a durable power of attorney for healthcare. You would typically find this on some of your healthcare documentations, especially when the patient is admitted to the hospital. This document is not the same as a durable power of attorney for one's finances. Let's understand that. This is one that is for healthcare, not finances. The DPA, or the durable power of attorney, is for one's finances, whereas though the durable power of attorney for healthcare is referred to as a healthcare proxy. You're standing in as a proxy or in place of the patient who is incapacitated. You're maybe referred to as a healthcare agent or surrogate decision maker. but they don't make health care decisions until a physician states that the patient lacks the capacity to make decisions on their own. So you have to wait until their cognition is impaired before you can enact this authority you've been given. To have decision-making ability, a person must be able to perform at least 3 tasks. They must be able to receive information, not necessarily be totally oriented, of course, but they should be able to receive information, should be able to evaluate it, deliberate, and mentally manipulate the information as well, and communicate a treatment preference. The second part of the advance directive is a living will, or LW, which identifies what one would or would not want if he or she were near death. Treatments that are discussed include CPR, artificial ventilation, artificial nutrition and hydration. And so it is up to them if they don't want any of these therapies. The third type of advance directive is a do not resuscitate, or DNR, or do not attempt to resuscitate order, which is signed by a physician or other authorized primary care provider. And it does instruct what CPR, whether or not it's to be implemented, CPR, in the event of the fact that someone stops breathing or they don't have a heartbeat anymore. Now, DNRs or DNARs are intended for people with life-limiting conditions for whom resuscitation is not prudent. I mean, some people, they may have a terminal cancer, and even if you do bring them back, the quality of life will just not be there. So this is what these types of orders are for. Now, depending on the state of residence, people who have made decisions not to be resuscitated may have what is called a portable DNR documents or bracelets to identify themselves as having directions not to resuscitate. By law, all primary care providers in the U.S. must initiate CPR for a person who is not breathing, or if they don't have a pulse, if you don't have that DNR order. Otherwise, that can spell some significant issues for you. The problem with performing a CPR is that it can be a violent and likely painful intervention that prevents a peaceful death. I mean, people, their ribs are cracked, their sternum, I mean, can be pretty violent. As a family member, if I had another family member who was in a situation like that, something I wouldn't really want to, witness or observe, even though I've been in so many of them. Now, patients and families do not understand the limitations of CPR, and they don't realize that it was never intended to be performed on patients with end-stage diseases. So, and I would say that, well, when it's end stage, I mean, that is the later stage, end stage. But obviously in the earlier stages, then we're talking about a different story in that case. As far as hospice and palliative care, now hospice is an interdisciplinary approach to facilitate quality of life and a peaceful death. And I'm sure many of you have heard of hospice. It neither hastens nor postpones death. It just kind of allows it to occur while the patient is more comfortable. It is for those who are typically who have typically 6 months or less to live. Now, as far as palliative care, philosophy of care for individuals with life-threatening illness, but the prognosis may be greater than 6 months. And this is just basically to provide them with comfort. And actually, when I took a palliative, I think it was some kind of palliative 1 credit hour course I took when I went to Jacksonville University, It's like a 6-week course. And basically, in this course, I discovered that when a patient is dying and, when they're terminal and they have a significant amount of pain associated with their disease process, providing them with adequate pain relief actually extends their life a little longer, but they're more comfortable, of course. So something to take into consideration. Now, the concept of hospice in the U.S. and other countries came about from a grassroots effort in response to the unmet needs of those who are terminally ill. And now hospice does use a team-oriented approach to providing expert medical care, pain management, emotional and spiritual support, expressly tailored to the person's needs and their wishes. So it is individual. Hospice systems of care are provided in a variety of settings. It could be in the home, it could be in a skilled nursing facilities. Rarely is it done in a hospital, in an acute care hospital setting, which is too expensive for that. And then they have some hospice units where patients can go to. Now, hospice services may be provided in non-health related institutions such as prisons. It can be done in the prison system as well. As far as palliative care, again, the philosophy of care for people with life-threatening diseases that help patients and their families identify their outcomes for care, it assists them with informed decision-making, and facilitates quality symptom management. So with palliative care, the symptoms are controlled a whole lot better. Take a look at table 7-2, and it compares palliative care to hospice care, because some people might think it's the same, but remember, one is greater than 6 months palliative care that these patients may have to live, and the other is less than 6 months, which is hospice. And but both, I mean, you're trying to provide comfort to these patients. Now, despite these benefits, palliative care is often not implemented until late in the patient's illness. Because, I mean, if you don't explain to these patients the difference between palliative versus hospice, they might think you're talking about hospice, meaning you're trying to put my family member in the ground too soon. So you really want to become more knowledgeable about palliative care and explain it to caregivers, patient even, because the patient might want to provide, or they might want palliative care as far as their advanced directives are concerned. Now, to accomplish this desired outcome, nurses need to have knowledge of end-of-life care. They must have compassion. We must be advocates of our patients, and we must also use therapeutic communication skills that you will learn in mental health next term. So this is why we're having this discussion now, so that you can understand what this is all about. One example in table 7.2, as we compare hospice and palliative care, is like I said, patients have a prognosis of 6 months or less to live, versus patients can be in any stage of a serious illness with palliative care, etc. So just go ahead and make sure you read that box. Good information for you to be aware of. Now, as far as physical assessment, what we note in these patients who are dying, they have cool extremities. They sleep a lot. Their PO intake is decreased. They're incontinent. They're congested. Then you hear these gurgling lung sounds. There's also changes in breathing patterns, something called Cheyne-Stokes respirations. And Professor Thody, who will be your mental health instructor, told me to let you guys know you need to know about Cheyne-Stokes respirations, and you do. Not to be confused with Kussmaul respirations. Cheyne-Stokes respirations are more related to those who are dying, whereas though Kussmaul, which can lead to dying, is when patients have a lot of CO2 in their system, which we'll learn about that with acids and bases. There's also disorientation and as well as restlessness. So obtain information about the patient's diagnosis, their medical history, their recent state of health in order to identify the risk for symptoms of distress at the end of life, and so that you can provide some or alleviate some of those symptoms. For example, people with lung cancer, heart failure, or chronic respiratory distress are at risk or at high risk for respiratory distress, dyspnea, or shortness of breath as they decline. So there are some interventions that we can do to ensure that they're more comfortable. Now, as death nears, patients are often they often have signs and symptoms of decline in physical function, which is manifested by weakness, sleeping more, genital urinary dysfunction, breathing pattern issues, and so forth and so on, cardiovascular problems. Now, when we talk about periods of apnea, and Cheyne-Stokes respirations. What this basically is apnea alternating with periods of rapid breathing. So apnea meaning there's no breathing at all, and then all of a sudden they start breathing really fast. And this is pretty common with those who are dying and at the end of life. Now, as patients' level of consciousness decreases, they might lose the ability to speak. When caring for those who are unable to communicate their distress or needs, we must identify alternative ways to assess symptoms of distress. So again, we can alleviate their symptoms. So we have to also teach family members how to perform interventions that can help relieve discomfort and stress as described in your textbook in chart 7-1. So take a look at that. So for example, circulation to the extremities decrease. And this is why they have cool extremities, right? And so the skin may become mottled or discolored. And so you want to cover these patients with a blanket. Also, fluid and food decrease. So do not force the person to eat or drink, or offer small sips of liquids or ice chips at frequent intervals if the person is I should say, don't force them to eat or drink, but you can offer small sips of liquids, ice chips at frequent intervals if the person is alert and are able to swallow. So you can do that, but don't force these patients to eat. Would you want to eat and you're dying, especially if you're at that point? I mean, food would be insignificant for you at that point. At least that's the way I would see it. As far as the psychosocial aspect or assessment, what we're looking for is in these patients is their level of anxiety increasing. They have difficulty coping. There's fear. There's also with withdrawal. The person is preparing to let go from surroundings, from relationships. They have vision-like experiences. The person may talk to people you can't see or hear and see objects. So they have that change in mental status. They see objects or places not visible to you. All a part of the process, the dying process. As far as letting go, the person may become agitated or continue to perform repetitive tasks. And also they have ways of, saying goodbye. Now, people facing death may have fear and or anxiety, as I mentioned, about their impending death with difficulty coping. So we want to assess cultural considerations, values, their religious beliefs, the religious beliefs of the patient, the family, because they have an influence on the dying experience, and how their symptoms are controlled, and as far as family bereavement. So this is why culture is so important for you as nurses to understand. You must be culturally competent to provide better comfort and better quality of life for your patients. Be aware that patients differ in their needs at the end of life, depending on their culture and their spiritual needs. So something that cannot be ignored. Take a look at also chart 7.2 for common emotional signs of approaching death. So take a look at that. And then we get into desired outcomes, needs and preferences are met. We must know what our patients' values and preferences are. Control of symptoms of distress, meaningful interactions with family. These are things that we want to see. And also a peaceful death. These are the desired outcomes, if you will. Now, interventions plan to meet the physical, psychological, social, spiritual needs of patients are done using a coordinated interprofessional healthcare team approach to end-of-life care. So make sure you utilize a team approach to do so. When developing a plan of care for people nearing the end of their lives, consideration should be given for where the person wants to die. A large percentage of Americans would like to die at home. That may not happen for me, but who knows? I don't know. So the most common end-of-life symptoms that can cause the patient distress are pain, weakness, breathless or dyspnea or shortness of breath, as well as nausea and vomiting. These are things that people may find distressing. So, and these are things that we can impact in a positive way, such as providing oxygen, providing pain relief, maybe counseling with a mental health provider. So, as far as pain management is concerned, pain is the symptom that dying patients fear the most. Can you imagine? So we want to, this is, how we can alleviate this particular symptom. Schedule pain medications to prevent recurrence of pain. Consider alternative administration route of pain medications as needed. Kind of new stuff. Now, diseases such as cancer, they often cause tumor pain as a result of infiltration of cancer cells into organs and nerves and bones. All right, so as that tumor grows, it just puts pressure on these areas. Other causes of impaired comfort in dying patients include osteoarthritis, something you might be dealing with, especially, I mentioned earlier, these patients, most patients, they die 65 years and older. So osteoarthritis has probably set in by that time. There's also muscle spasms and stiff joints secondary to immobility. Both non-opioid and opioid analgesics play a role in pain management near the end of death. So both of these agents should be considered. Now, patients who have had their pain controlled with either short or long-acting opioids should continue their scheduled doses to prevent recurrence of the pain. Now, keep in mind your long-acting oral opioids, they generally cannot be crushed. They can be provided rectally, transdermally, intravenously, as well as subcutaneous route might be necessary if you can't crush it. Now, short-acting non-opioids such as acetaminophen or Tylenol, opioids such as morphine, sulfate, oxycodone, hydromorphone elixir can also be given sublingually under the tongue, which you all should be familiar with. As far as patient-centered care, remember we talked about that under when we talked about the different nursing concepts in the first presentation. Pain in older adults is often underreported and also undertreated. Do not withhold opioid drugs from older adults at the end of their lives, is what we are instructed or taught to do. Instead, we might want to just give them lower doses of opioids initially with slow increases, because remember, they don't metabolize medications like they used to, and their renal function is on a decline as well. And we also want to monitor for changes in mental status or excessive sedation as well when giving these pain medications. Now, remember we talked about in the second presentation about complementary and alternative therapies, or CAM. These can consist of massage, music therapy, therapeutic touch, and aromatherapy. Now, non-pharmacologic interventions are also integrated into the pain management plan. Massages may decrease pain in people with cancer, and is one of the most popular complementary interventions used for patients at the end of their lives. And also go ahead and read the rest of the information here. I did provide some additional information about music therapy, therapeutic touch, and also aromatherapy. So take a look at that. I don't want to bore you with all that information, something you can read. Some of these slides I may just refer you to the reading in the slide, so it's not to bore you to death. All right. All right. I think I may have went too far. All right. So we're talking about weakness management. Here we must deal with aspiration precautions, because if these patients are weak, even their muscles of swallowing can also be impacted. So, and they're not able to sit up, while they eat and whatnot. So we have to be concerned about aspiration precautions. We must also pay attention to mouth care, moisturizing, also the lips, and also altered routes of medication administration. Choose the least invasive route with the most effective treatment. I mean, these patients are already uncomfortable, and then we go doing these, we administer certain routes of treatment that may cause even more discomfort. Now, patients commonly experience weakness and fatigue as death nears. At this point, they are generally advised to remain in bed in order to avoid any falls or injuries and whatnot. Right. Now, weakness combined with decreased neurologic function may impair the ability to swallow, as I mentioned. So once the patient has difficulty swallowing, oral intake should be limited to soft foods and sips of liquids, offered but not forced, as I mentioned before. Teach families about the risk of aspiration and reassure them that anorexia is normal at this stage, and families may request that IV fluids be started as a way to hydrate them. Inform the families that giving fluids can actually increase discomfort in a person or patient with multi-system slowdown. They may become fluid overloaded. So may lead to impaired comfort from fluid replacement It can lead to more respiratory secretions, which leads to respiratory distress. There might also be increased GI secretions, nausea, vomiting, edema, as well as ascites. The distended abdomen is ascites. You have all this fluid in the peritoneal cavity. Now, to avoid a dry mouth and lips, moisten them with soft applicators and apply an emollient to the lips as well. As far as dyspnea or shortness of breath, SOB is what we call it. This is for non-pharmacological management. These would include providing cool air, wet cloths to the face, positioning to facilitate chest expansion, frequent rest periods, and also encouraging imagery, get their minds off of things, and deep breathing. So make sure you understand these modalities because you, as a nurse, you must know what those interventions, non-pharmacological interventions might be. You're at the bedside with these patients mostly, and to have knowledge of this can help alleviate their distress. Now, dyspnea is a subjective experience. It's what the patient is feeling, in which the patient has uncomfortable feeling breathlessness. Common symptom of distress. This is a common symptom of distress near the end of life, especially amongst older adults because of decreased oxygen reserves due to aging. We're on a decline as we age. Dyspnea can be directly related to the primary diagnosis, meaning, for example, lung cancer, breast cancer, or secondary to primary diagnosis like pleural effusion related to treatment of a primary disease, for example, heart failure caused by chemotherapy. And there's some additional information there for you to read as well. We always want to perform a thorough assessment of the patient's dyspnea, include the onset, severity, and any precipitating factors. What leads to the patient's dyspnea, and we can quantify that or measure that on a scale of 0 to 10. Precipitating factors may include the time of day. What position causes it? Is it related to anxiety or pain, or coughing, or some kind of emotional distress as well? Now, as far as pharmacological management, that's kind of like the color of that. Hold just a minute. I'm gonna be able to do that. I like color text. All right, that's better. Anyway, so we talked about non-pharmacological management, and so here, as far as dyspnea is concerned, the dyspnea management, we get into the pharmacological management. We're treating the primary cause. We want to relieve psychological distress that accompanies symptoms. So what do we use? Opioids, anticholinergics, which decreases secretions. Bronchodilators helps these patients to breathe. Sedatives, corticosteroids, oxygen therapy, diuretics, as well as antibiotics. Now, since you guys just had pharmacology, I did provide you with some really good notes here. And so what I would have you to do is to read each one. It deals with each of these modalities here, the opioids, anticholinergics, and so forth. So go ahead and take a look at that. Let's see what I have here. One that's like that. All right, so yeah, anyway, go ahead and take a look at that. I think I'm just looking over it just to make sure it's pretty, not self-explanatory, but easy to understand. So you should be fine with this. If you have any questions, go ahead and let me know, and we can go over it some more. But I think you'll be fine. And some of these medications might be on your midterm pharmacology HESI as well. So make sure you know them well. And these are some additional medications that I'm going to have you look at. You have your anti-emetic agents, you know, helps people or prevents vomiting. And also to add to this, we want to remove any source of odors. Think about if you have a bedside commode near your patient and they have a bowel movement, or somebody else, they're in a semi-private room and that person may have a bowel movement, or the trash may be full of whatever, or the linen cart may be full of, not the linen cart, but the linen, the dirty laundry cart may be full of, you know, SHIT or whatever. Anyway, so just make sure that you remove these items, because can you imagine this patient is experiencing nausea and whatnot, and then you have these unpleasant odors. So also make sure the room is comfortable as well. There should be a comfortable room temperature. So make sure you take a look at the rest of this information. One of the things here where it talks about if constipation is identified as a cause of the nausea and vomiting, we want to give the patient a biphosphate enema or fleet enema to remove stool quickly. And it talks about if stool is in the rectum, if stool in the rectum cannot be evacuated, meaning removed, a mineral oil enema is followed by gentle disimpaction, meaning you have to put your finger in the patient's rectum and pull out the stool. Yep, you do. I know that may sound tough, like a tough job, but sometimes we may have to do that. It can relieve the patient's distress. Nausea and vomiting related to other causes can be controlled by one or more antiemetic agents such as compazine, Zofran, Decadron, Reglan. Anyway, so this is what you have here. So take a look at this information. As far as restless and agitation management, we want to assess for pain, urinary retention, constipation, and other reversible causes, because these issues can cause the patient to be restless and agitated. We always want to treat the underlying cause. We might have to provide pharmacological agents such as haloperidol or Haldol. We certainly give these for patients who are agitated. This would be one of your big ones that you'll see in the hospital. Complementary and alternative therapies, or CAM, such as music and aromatherapy, is also initiated. So make that a little smaller. So agitation at the end of life first requires assessing the patient for all these symptoms that I just mentioned. And if these are ruled out, then you may want to just look at delirium, especially if the confusion is acute, if it came on rather quickly. The patient may be suffering from acute delirium, which is treated differently than a patient who is just has been pretty confused for a pretty long time, because the delirium may be due to some cause that can be reversed fairly quickly. Now, when we think about delirium, it's an acute and fluctuating change in mental status, and it is accompanied by inattention, disorganized thinking, and/or altered level of consciousness. It can be hyperactive or hypoactive or mixed or both. When it's hypoactive, it's referred to as quiet, meaning delirium is probably not uncomfortable for the patients. But then you have the agitated, noisy delirium with psychotic and behavioral symptoms, which can be uncomfortable, especially for the family who's sitting by and looking at this. The patient may be yelling and having hallucinations, seeing pink elephants, and whatever the case is. So this can be very uncomfortable for the family. When delirium occurs in the week or two before death, it is referred to as a terminal delirium. So it may not be a lot to do, but possible causes include adverse effects of opioids, benzodiazepines, and anticholinergics or steroids. Remember, as this patient is dying, their systems are shutting down and they can't metabolize, they cannot excrete the metabolites of these drugs, so they basically accumulate. If medications are suspected causes, you may have to either decrease or discontinue them if necessary. Do not give the patient more than one antipsychotic drug at a time because of the risk for adverse drug events. So if you give too many of them at one time, then you don't know which one is causing the problem. A neuroleptic drug such as low dose Haldol, 0.5 to 2 milligrams orally, IV, or subcutaneously, or even rectally is commonly used at the end of life. Haloperidol or Haldol has the potential to cause extrapyramidal symptoms, those symptoms you see in Parkinson's patients, or adverse cardiovascular events and death in older adults with dementia. Benzodiazepines generally are not used as a first choice for older adults with agitation because of their risk of causing delirium. So we may want to hold off on those. And then, of course, complementary and integrated health, or CAM. The music therapy may produce relaxation and quieting of the mind and promoting a restful state. So don't discount the power of music in these situations. Aromatherapy with chamomile may also help overcome anxiety, anger, and tension, stress, and insomnia in dying patients. And then we have interventions for providing psychosocial support, their presence, life review, reminiscence, spirituality, and also religion. Now, the personal experience of dying or losing a loved one through death is life-altering. Unexpected deaths, particularly in young people, tend to be the most traumatic. Now, whereas death is the termination of life, dying is a process. So people facing death may demonstrate emotional signs and symptoms of their response to the dying process through behaviors that equate to saying goodbye, or through actual withdrawal from the situation. Hold just a minute. Get something to drink in my mouth. Get a little tongue-tied. Other psychological concerns is seizure management and also refractory symptoms of distress. When we talk about the word refractory, basically, no matter what you do to try to, let's say, treat someone's pain and it's not working, it's refractory pain or refractory distress or refractory whatever it is. If you can't treat it with, the common therapies, if you will, then their symptoms are known to be refractory to whatever that treatment is. So in this case, refractory symptoms are distress. So they talked about proportionate palliative sedation. So we do try to sedate these patients. Now, seizures are not common at the end of life, but may occur in patients with brain tumors, advanced AIDS, and pre-existing seizure disorders. Around the clock, drug therapy is needed to maintain a high seizure threshold for patients who can no longer swallow anti-epileptic medications. Benzodiazepines such as Valium, and Ativan are the drugs of choice for these patients who are prone to seizures. Now, patients receiving opioids for pain or dyspnea or other drugs such as antiemetics or anti-anxiety agents may experience mild sedation as a side effect to the therapy. These drugs actually cause some sedation, so be careful with that. It is important to understand that drug therapy for symptoms of distress at the end of life are guided by protocols. So using medications believed to be safe with the intent of alleviating the patient's suffering. There is no evidence that administering medications for symptoms of distress using established protocols hastens their death. It doesn't make them die faster. So that would be a concern for some of us because we don't want to give too much of the medication that we feel might kill the patient. Now, a small percentage of patients have refractory symptoms of distress that do not respond to treatment near the end of life. So these patients may be a candidate for proportionate palliative sedation. It is a care management approach involving the administration of drugs such as benzodiazepines, such as midazolam, or Versed, you may have heard before, neuroleptics, or seizure medications, or barbiturates, or anesthetic agents such as propofol, the drug that killed Michael Jackson, for the purpose of decreasing suffering by lowering the patient's consciousness. So you want them less conscious. The intent of proportionate palliative sedation is to promote comfort and to not hasten death, which is distinguished from euthanasia. It's not the same as euthanasia. And that would be some of our concerns, I'm sure. And so here we get into the grieving process, which consists of grief, mourning, being with versus being there, life review, reminiscence, spirituality, and cultural awareness. Now, let's see. And actually, I'm going to leave this to you guys as well. This is pretty easy to understand as well. For example, reminiscence is the process of randomly reflecting on memories of events in one's life. The benefits of storytelling through either method provide the ability to attain perspective and also enhance meaning for the patient. As far as religion, which is formal belief systems that provide a framework for making sense of life, death, suffering, and also responding to universal spiritual questions. And of course, we talk about physical manifestations indicating that death has occurred. Breathing stops, the heart stops beating, pupils become fixed and dilated, body color becomes pale and waxen, and also the jaw may fall open, etc. So there's some additional information there. But anyway, read the rest of this information about the grieving process. There's a table that I'm going to refer you to, which is table 7-3 regarding basic beliefs regarding care at the end of life and death rituals for selected religions such as Christianity, Judaism, as well as Islam. So take a look at that. And then we get into post-mortem care. There are legal considerations as far as pronouncement of death, the death certificate, a determination of the need for an autopsy, and also transfer of the body. This all involves postmortem care. Now, if death was in the home and it's expected, um, you should not call 911. If somebody is dying and we know they're dying, maybe they're in hospice or something like that, you don't have to call 911. If the person was a patient in a hospice program, the family just calls hospice. If a death is unexpected or suspicious, the medical examiner is notified at that point. Otherwise, the nurse or primary health care provider performs the pronouncement and completes a death certificate as well. Be sure to check your healthcare agency policies for who can pronounce death and specific procedure to follow. Typically, the physician did this in our healthcare institutions. Now, as far as pronouncement of death, we want to note the time of death that the family or staff reported the cessation of respirations. So document that. Do a quick note for yourselves. Identify the patient by identification tag if in the facility, and note the general appearance of the body. All right. We want to ascertain that the patient does not arouse to verbal or tactile stimuli, like you digging your knuckles into their chest wall. Avoid overtly painful stimuli, especially if family members are present, because they might think you're abusing the patient's body. So be careful with that. Auscultate for absence of heart sounds, palpate for absence of carotid pulse as well. Document the time of pronouncement and all notifications in the medical record. In other words, maybe the attending physician may be the one doing this. Document if the medical examiner needs to be notified. It may be required for unexpected or suspicious deaths. Document if an autopsy is planned per the attending primary care provider and the family. We want to look and listen for the absence of spontaneous respirations. There's some additional information there for you to read. After the patient dies, ask the family or other caregivers if they would like to spend time with the patient to help them cope with what has happened and to say their final goodbyes. As far as before preparing the body for transfer, ask the primary care provider whether an autopsy will be required. When death is expected, an autopsy is not likely. An autopsy is generally performed only when the cause of death is not known. Some religions, such as Orthodox Jews, do not allow autopsies. So keep that in mind as well. Which is why we learn about other cultures, right? Now, after the family or significant others view the body, follow agency procedure for preparing the patient for transfer to either the morgue or a funeral home. In the hospital, a post-mortem kit is generally used with a shroud and identification tags. Take a look at chart 7-5. It describes best practice guidelines for postpartum care. And so I'll have you to go ahead and read this information. It's pretty straightforward. And it is in your book in chart 7.5. So take a look at that, please. And now euthanasia. All right. So withdrawing or withholding life-sustaining therapy there's an acronym they refer to as WWLST, formerly called passive euthanasia. Now, that one I don't believe is so illegal, but the active euthanasia, actively causing death, not supported by most organizations and legal in some situations in some states. So that one is not quite legal, except depending on where you are. I don't know if you guys remember Dr. Kevorkian or something like that. Now, euthanasia is a term that has been used to describe the process of ending one's life. We talk about active euthanasia, which I just mentioned. you're purposely or directly causing someone's death. Um, Active euthanasia, even with the patient's permission, is not supported by most healthcare organizations in the U.S., including the American Nurses Association. Now, you do have a physician-assisted suicide, sometimes referred to as assisted dying, is gaining worldwide public support. A few European countries have had legalized physician-assisted suicide for terminally ill patients for a number of years. Now, that WWLST, formerly called passive euthanasia, involves discontinuing one or more therapies that might prolong the life of a person who cannot be cured by the therapy. Feedings and such as that. Another phrase sometimes used is letting the person die naturally. I like that one better. If you just withdraw anything that is not natural, allowing a natural death to occur. The U.S. court system also supports withdrawal of aggressive treatment and the rights of surrogate decision makers to refuse or stop treatment. I think that's humane. Now, in a newer concept as the legal alternative method for death in all 50 states is voluntary stopping of eating and drinking, also called terminal dehydration. You guys probably remember the case on the west coast of Florida. I think it was Tampa or something. Now, with this particular approach, competent patients with a terminal or incurable disease or illness refuse to eat or drink in order to hasten their death. Nurses are usually in the best and most immediate position to discuss these issues. So in order to do this, we have to be knowledgeable about terminology, ethical issues related to death and dying. In all cases, the principles of informed consent must be met. The patient is competent, the death is voluntary, and the patient understands the benefit, the burden, and consequences of the death. And folks, we have come to the conclusion of this presentation, which is a good thing. If you guys have any questions or concerns for me, please go ahead and direct those to me. And this will conclude this presentation. Thank you, everyone.